Good afternoon. Thank you for joining me today. My name is Dr. Arthur Goldstein. I am the medical director for the Center of Wound Healing and Hyperbaric Medicine at Olean General Hospital. Today I'm going to give you a quick tour of the types of wounds that we see in the center and give you a little information about who you need to refer to us, but more importantly, when you need to refer to us. First, I'm going to go over some of our patient demographics. This is typical of the patient population that we see at the Olean General Wound Center. Venous disease, including chronic venous insufficiency and acute post-phlebitic syndrome, along with varicose veins, is probably the largest group of patients we see. 30 to 40% of our patient population is venous disease. Up number two are diabetic patients. These are mostly foot and lower extremity ulcers, and they can be with both acute and chronic infections, including bone infections called osteomyelitis. This is about a quarter of our patient population. Arterial disease, or what we term chronic critical limb ischemia, is next, probably 15 to 20%. We see a wide variety of pressure ulcers, surgical wounds, and traumatic wounds. We get these referred by other patients or by the emergency room. And then we have what I call unusual ulcers or unusual conditions, ranging from vasculitis to pyoderma gangrenosum to Berger's disease, Raynaud's disease. We will see minor burns in the wound center. Anything major, I'll refer up to Buffalo. We see lymphedema and lipedema. And important to us are patients who have radiation injuries, particularly chronic ulcers. We see radiation injuries to the bladder, radiation cystitis, and radiation colitis to the colon. This usually occurs from pelvic radiation for certain malignancies, particularly in men being treated for prostate cancer. One also needs to know that there's a large overlap between these patient categories. We could see a patient with a diabetic foot ulcer who winds up being an arterial patient as well, and vice versa. Venous disease can be mixed disease, including about 20 to 25% of patients who will have arterial disease and venous disease. Wound and ulcer locations also vary, although please note that about 70% of the ulcers that we see are either on the foot, toes, or lower extremity. This is by far and away the largest body part where we see our wounds. However, we see wounds all over the entire body, including the trunk, upper extremity, and head and neck. Let's talk just a little bit about venous disease and the type of patients we see here. We see here the spectrum of venous disease, a patient here with bilateral ruberous swollen legs, typical of venous disease. Same for this particular patient. Legs are swollen and discolored. When venous disease starts to break down, we can get early weeping, also known as venous dermatitis. Here the patient will present with weepy, itchy legs. This last patient down here in the corner is someone with venous dermatitis who is just about to ulcerate. You can see in this area the ulcer just beginning to form. Here's another spectrum of venous ulceration. Most of the venous ulcers are going to be in the medial ankle, or what we call the gaiter area, as seen in this particular patient and this particular patient. You could see here in this patient, the ulcer is a little bit more anterior, but there's a large varicose vein feeding this area of venous insufficiency where the discoloration is localized and the ulcer is localized to the same area. Ulcers can occur on the lateral leg or on the anterior leg. All of these patients have in common is venous insufficiency, either from varicosities, deep vein thrombosis, or insufficiency of their main veins. Let's talk a little bit about diabetic foot ulcers, another large population for us and very important. I put up on these 3 slides sort of a spectrum of the same type of ulcer. This area under the big toe, what we call the submetatarsal number 1 area, is very prone to pressure. Patients normally walk heel to toe, with most of the pressure being on the heel and on this submetatarsal 1 area. Here you could see a callus forming here. If this patient doesn't get into their foot doctor soon, this area will break down. We come to the next stage where we've got what we would call a Wagner's 2 ulcer. The ulcer has formed and is into the subcutaneous tissues. If this ulcer progresses because of poor weight distribution and neuropathy, the ulcer is going to continue to progress where we get a much deeper ulcer. This particular patient is probably what we call a Wagner's 3. The ulcer is down into the muscle. This patient needs to be evaluated for osteomyelitis to make sure that the infection and ulcer is not involving the bone. Basically, this is a neuropathic process due to the patient's weight distribution and neuropathy. These patients cannot feel this ulcer forming. If they don't look at the bottom of the foot, they may never know this ulcer or this callus is even there. Another common problem we see with diabetic patients is the formation of a Charcot foot. A Charcot foot forms because of the neuropathy. And what happens is, as seen in this first slide, they get the midfoot starting to degenerate, and the midfoot and the arch actually collapses. So rather than walking on the heel and that submetatarsal area that we talked about, they're actually walking on the midfoot area, and that predisposes them to ulcerations, as you see in these pictures here. The arch has collapsed, and they formed a midfoot ulcer. This particular patient also has a heel ulcer, basically walking on the heel and the midfoot. This is abnormal pressure distribution, and these areas are not meant to take the pressure of daily walking. Hence, the area will ultimately ulcerate. Neuropathy, again, remains a big problem in Charcot patients. Finally, I got a slide here basically showing the spectrum of diabetic disease. We can get arterial disease in diabetics causing ischemic toes. We can get shoe trauma. Whenever we see an ulcer on the dorsal toe, it probably means they're walking around in shoes that are not fit properly. We see a lot of this in this slide up here on the right-hand side, with this toe taking the brunt of trauma from the shoe, forming ulcerations. You could see it all along. The other common area we'll see ulcers with poor fitting shoes is on the tips of the toe, where the patient is walking and maybe sliding a little bit in the shoe and causing trauma to the tips of the toes. Being that we care for diabetic patients, about 25% of our population, we do a lot of diabetic teaching. And this is a particular handout that we'll give to our patients in terms of teaching them how to care for their feet. Everything from their physician checking for diabetic neuropathy to visually observing their feet on a daily basis, cleansing their feet carefully. I don't recommend that any diabetic cut their toenails. We like to refer most of our patients to one of the local podiatrists. This is particularly good for patients with fungal toes, because those nails tend to be very thick and brittle and are difficult to trim. Another key aspect is for diabetics never to walk barefoot and never to walk with open-toed sandals or shoes. So this is a typical handout that we might give our diabetic patient to give them some education in how to care for their feet, hopefully preventing them from coming back to us a second time. Unfortunately, we get a lot of return customers. Lastly, I have a slide here on ischemia or chronic critical limb ischemia and gangrene. Ischemic ulcers are notorious for being the most distal on the foot. They'll usually occur on the toes as little blackened ulcers. You could see that in these three pictures here. Also note the discoloration to the foot. We call this discoloration vascular rubor, and it is much more obvious when the patient puts their foot dependent, as is seen in this picture. You could see here the toes turn almost a cherry-colored red here. If you were to raise this foot up, it would become pale. Note the ischemic ulcer here, again, dry on the ankle. This is kind of an unusual patient here. This patient actually had normal circulation. They have bounding pulses on the foot, but she dropped a frozen piece of meat on her toe. And the toe, because of the trauma, developed a bad contusion and eventually became gangrenous. She has a cellulitis spreading up the foot. It's been marked here. Fortunately for her, the circulation is good. She underwent a toe amputation and healed beautifully. So even patients with normal circulation can develop gangrene of their toes, and it's much more common in our diabetic population. So finally, we get to who to refer and when. I'm going to go through this and take this through the three large categories of disease we just spoke about. Number one is arterial disease. If you suspect a patient has arterial disease, these patients need urgent referral because they're going to deteriorate more rapidly than any other patient we see due to the lack of circulation. Please try and order an urgent PVR test. Typically, this might mean a phone call over to the vascular lab at the hospital in order to obtain this test on a more urgent basis. We highly suggest that ischemic ulcers be kept dry. Dry gauze covering is more than satisfactory. Talking about diabetic patients, typically patients with an ulcer on their foot that's present for more than 2 weeks needs to be referred to us. A lot of physicians will talk about a 30-day mark, but I just think that's too long for a diabetic patient with an ulcer to be referred into us. If they've had the patient for 2 weeks and it takes another week or so for them to get in, they've got an open sore on their foot for close to a month, and that's getting to be pretty long. These patients also need some of the most complex coordinated care that we do in wound care. Many of them will need surgical debridement, local wound care, local offloading of the ulcer, imaging, lab tests, and some of them are possible hyperbaric oxygen patients. If not ischemic, you could use an antibiotic cream or ointment sparingly with a dry gauze dressing. Please do not use Telfa as it does not absorb any drainage, and please do not use Neosporin. Bacitracin ointment works very well along with mupirocin cream or ointment. Talking about venous disease, again, someone has classic venous disease with an ulcer for more than 2 weeks, we need to see them. Usually they need concomitant edema control, which means compression. And do not compress somebody without a PVR test. Most of the patients coming in with venous disease have either been previously tested or we will test them prior to compressing them. Most of the venous ulcers you'll see will have a lot of drainage. Dry gauze dressing will need to be changed usually several times a day. For this reason, we avoid nonstick pads. What also works very well for this group of patients are the pediatric diapers, which are very absorptive, or even some sanitary pads that have the gel internal matrix because they absorb well and don't need to be changed as often. Patients should also elevate the extremity until they get in to see us. As a general dictum for anybody treating their own patients for wounds, if you've spent more than 2 weeks trying to heal a patient and the ulcer is not responding or is worsening, please refer that patient to us for care. We're happy to assist you with the care of your wound patients. If you feel you need an urgent or emergent referral, please call me directly at the wound center. I'd ask you not to use my cell phone because if I'm in with a patient, I usually will not answer it. But if you call me directly, my secretary will come and grab me out of the room if need be. Usually I'll have you text or email a picture of the wound so we can make decisions regarding initial local care and triaging that patient to me for care. Obviously, we don't want any patient identification on those emails or texts, but a picture is worth 1,000 words. I want to thank you for joining me this afternoon. Again, if you have any questions, concerns, please don't hesitate to reach out to me at the Wound Care Center. Thank you very much.